So welcome to the class. Today's topic is management of gestational trophoblastic disease. It is a Green Top guideline number 38. It is published in September 2020. So we will see about the executive summary of this particular guideline. So what is the most common presentation of gestational trophoblastic disease? It is the most common presentation is irregular vaginal bleeding, positive UPT and supporting ultrasound evidence. So commonest is irregular vaginal bleeding. Less common presentations are hyperemesis, excessive uterine enlargement, hyperthyroidism, early onset preeclampsia, and abdominal distension due to theca lutein cyst. And very rarely, the patient may present with hemoptysis or seizures due to metastatic disease affecting the lungs or brain. Definitive diagnosis of molar pregnancy is made by histological examination. So remember, there may be a simple question: what is the commonest presentation of gestational trophoblastic disease? Remember, it is irregular vaginal bleeding, because when you see all features, you feel that okay, it could be irregular vaginal bleeding, it could be hyperemesis or excessive uterine enlargement. The commonest is irregular vaginal bleeding along with positive UPT and supportive ultrasound evidence. Okay. And rare presentations are hemoptysis and seizures. These are rare. Less common are hyperemesis, excessive uterine enlargement, hyperthyroidism, early onset preeclampsia, and abdominal distension. Most of the time questions are very simple, but we get confused with the options. Okay, this is what happens in the final examination. So remember, read carefully, read and every word carefully you have to read. So what is the treatment then? Removal of molar pregnancy. Suction curettage is the method of choice for complete molar pregnancy. Okay, so if you have a complete mole, suction curettage. Ultrasound guidance during removal and curettage may be of use to minimize the chances of perforation and ensure that as much as tissue you have removed. Okay, so what is the recommended method for complete mole? It is a suction curettage, and if you have ultrasound facility available, it is better do it under ultrasound guidance, because then the chances of perforation will be minimized and as much as tissue we can take it out. Okay, if you have a partial mole, then what is the treatment for partial mole? Also it is a suction curettage, except when the size of the fetal parts deters the use of suction curettage, and then medical removal can be used. So depending upon the gestational age, if the fetal parts, because of what you can say large fetal size, if you are not able to perform suction curettage, then you can go for medical methods. Okay, then next is anti-D prophylaxis is recommended following removal of molar pregnancy. Cervical preparation prior to the uterine removal is safe. Okay, so you can do the cervical priming also. Then what about oxytocin infusion? Most of the time, olden people used to say that oxytocin should be started during the removal. But what the guideline says, oxytocin infusion during surgical removal or prior to the completion of the removal is not recommended. Okay, so oxytocin infusion prior to completion of the removal is not recommended. Significant hemorrhage prior to or during removal, surgical removal should be expedited, and the need for oxytocin infusion weighed up against the risk of tissue embolization. So when you use the oxytocin, there is a risk of tissue embolization. So it is not recommended during the removal of molar pregnancy. Okay. Now, what about the repeat surgical curettage? Okay, so almost always there is a role of urgent surgical management for women who are experiencing heavy or persistent vaginal bleeding causing acute hemodynamic compromise, particularly in presence of retained pregnancy tissue on ultrasound. Suppose if you have done a suction curettage, then when will you do the repeat curettage? If there is a ultrasound evidence of retained POCs along with heavy persistent bleeding, either heavy bleeding or persistent vaginal bleeding, which is causing the acute hemodynamic compromise. Remember, these particular sentences are important because it is not only the presence of retained pregnancy tissue on ultrasound, but associated heavy or persistent vaginal bleeding, which is causing the acute hemodynamic compromise, is an indication of repeat surgical removal. Okay. outside the context of acute compromise, there should be consultation with the relevant GTD referral center before performing management of the second time in the same pregnancy. So if there is no acute compromise in that particular case, what we are going to do, there is a GTD referral center where all these patients are referred. So consultation with the relevant GTD center is indicated before you take up any surgical management step. Is it clear?
Yes, sir.
So you have a case where surgical curettage has been performed and there is a retained POC and there is acute compromise because of heavy bleeding or persistent bleeding. We will go ahead with the repeat suction curettage. However, if there is no acute compromise in that particular case, it is indicated. So if there are multiple options, if there is no compromise, contact the or consult with the relevant GTD center will be the option. Okay. Now histological examination of the pregnancy tissue in all miscarriages. Okay. In routine, you are performing suction evacuation for miscarriage. What the guideline says, if no fetal parts are identified at any stage of pregnancy, then HP is recommended or histopathology is recommended following medical or surgical management to exclude the trophoblastic neoplasia. So when you are performing a suction evacuation for miscarriage, in that particular case, if you are not able to identify the pregnancy tissue, then you send it for histopathology. Okay. And there is no need to routinely send the pregnancy tissue for histological examination following therapeutic abortion, provided the fetal parts have been identified at the time of surgical abortion or prior to ultrasound examination. So if you have performed ultrasound and ultrasound shows proper fetus, well-formed fetus, then there is no need to send the sample for histopathology.
Yes, sir.
Okay, so this is very clear. Okay, so women who receive care for miscarriage should be recommended to do UPT 3 weeks after the miscarriage. So if you have done the given the care for miscarriage, ask the patient to repeat UPT after 3 weeks. So this beta HCG should come down to normal level after 3 weeks. Okay, now women who undergo medical abortion should be recommended to do urine pregnancy test 3 weeks after the procedure. So even if she undergoes surgical method or medical methods, the repeat UPT after 3 weeks, you have to advise so that the pregnancy event is completely over. Okay, that is a documentation. Then women with elevated beta HCG after a possible pregnancy event, suppose the beta HCG remains elevated, then referral to the GTD center should be considered for all women where there is a persistent elevated HCG, either after ectopic pregnancy has been excluded or after 2 consecutive treatments with methotrexate for a pregnancy of unknown location. So if there is a persistent elevation of beta HCG after a possible pregnancy event, you have to refer this patient to GTD center. It may be a case of first thing, you have to rule out ectopic pregnancy, and second, after 2 consecutive treatments with methotrexate for a pregnancy of unknown location. Okay, so these patients are to be referred to the GTD center. Okay, so even if you have given 2 methotrexate for pregnancy of unknown location and there is a persistent elevation of the SCG, you will refer this patient to GTD center. Okay, now any woman who develops persistent vaginal bleeding after pregnancy event is having at risk of GTN. Okay, so a woman who develops persistent vaginal bleeding after pregnancy event is at risk of gestational trophoblastic neoplasia. A urine SCG test should be performed in all cases of persistent or irregular vaginal bleeding lasting more than 8 weeks after the pregnancy event. Suppose either it is a miscarriage or there is a pregnancy event, but the bleeding is lasting for more than 8 weeks. So you have to do the urine SCG test. Okay, because these patients are at risk of development of the gestational trophoblastic neoplasia. Now, symptoms from metastatic disease such as dyspnea and hemoptysis or new onset seizures or paralysis can occur very rarely. Biopsy of secondary deposits in the vagina can cause major hemorrhage and is not recommended. Suppose if you have a secondary deposits in the vagina, you don't do the biopsy of those particular mets. Okay. Now, coming to the suspected ectopic molar pregnancy. Now you have an ectopic pregnancy and you are suspecting that this ectopic pregnancy is a molar pregnancy. Then what is the recommended treatment? If there is a local tissue diagnosis of ectopic molar pregnancy, the tissue should be sent to center with an appropriate expertise for pathological review. So you have to send the specimen again for pathological review to the respective center. Okay. Now you have a twin pregnancy with one viable fetus and you are suspecting the coexisting molar pregnancy. Okay. So you have a twin pregnancy in which one fetus is viable and other is a molar pregnancy. Now, what are the possibilities? You can have a combined molar pregnancy with a viable twin, or there is a if there is a diagnostic doubt, it should be referred to regional fetal medicine center and GTD center. So you have to refer these patients to regional fetal medicine center and GTD center, counsel for potential increased risk of parental morbidity and outcome for the gestational trophoblastic neoplasia. Okay, so you can have a twin pregnancy where there is a one viable fetus and other can be a molar pregnancy. These patients require referral to the fetal medicine center and the GTD center. So both referrals are indicated over here. Okay. Now consider prenatal invasive testing for fetal karyotype in cases where it is unclear if the pregnancy is a complete mole with a coexisting normal twin or a possible singleton partial molar pregnancy. Suppose you have a fetus and there is a mole, then whether it is a twin pregnancy with a one fetus and the other as a complete mole, or whether it is a singleton partial molar pregnancy, if you are not clear, then you have to do the fetal karyotype. Is it clear?
Yes, sir.
Yes,
Okay.
yes, sir.
So consider fetal invasive testing for karyotyping where it is not clear whether the pregnancy is a complete mole with a coexisting normal twin or possible singleton partial molar pregnancy. Okay. And prenatal invasive testing for fetal karyotype should also be considered in cases of abnormal placenta, such as suspected mesenchymal hyperplasia of the placenta. Then
We had
placental.
this patient in Unit 1.
Hello.
Hello. Yes, sir. Sir, we had this patient in Unit 1, the
Yeah,
patient that we aborted.
Yes. So wherever it is indicated fetal karyotyping, when there is a twin pregnancy and you are not clear whether it is a complete mole with a associated normal pregnancy, normal twin, or single partial molar pregnancy, and it is also indicated when you get a abnormal placenta such as suspected mesenchymal hyperplasia of the placenta. Okay. Placental site trophoblastic tumor or epithelioid trophoblastic tumor management. Now PSTT, that is placental site trophoblastic tumor, and epithelioid trophoblastic tumor management, all women with placental site trophoblastic tumor, that is PSTT, or epithelioid trophoblastic tumor, ETT, should be registered with and cared for within the GTD center. So these patients also require a referral to the GTD center. Okay. So in UK, they have referral center for these cases. So all the NHS hospitals will send referral to these cases to these GTD centers. Okay. Placental site nodule or atypical placental site nodule management. Okay. Now you can have PSN, that is placental site nodule, or atypical PSN. Now if you have a typical PSN, that is typical placental site nodule, it do not currently require further investigation or review. Okay. But if you have a atypical PSN, atypical placental site nodule, histology to be reviewed centrally. All women with atypical placental site nodule will then be called up for central review to discuss the existing data, perform staging investigation, and to determine the further management. So if you have a atypical placental site nodule, then definitely these patients require a referral. Then the pathology should be reviewed centrally, and staging investigations are to be done, and further management is to be decided in consultation with the referral center. Okay. Now which patients require registration at GTD center? Okay. All women diagnosed with gestational trophoblastic disease, such as complete or molar pregnancy or partial molar pregnancy, twin pregnancy with complete or partial molar pregnancy, then limited macroscopic or microscopic molar change, suggesting possible early complete or partial molar pregnancy or choriocarcinoma. Okay. then placental site trophoblastic tumor or epithelioid trophoblastic tumor ETT, and atypical placental site nodule. So these are the indications for referral to GTD. One very simple: complete molar, partial molar, twin with complete or partial molar, then limited macroscopic or macroscopic molar change, which suggest either early complete or partial molar pregnancy or choriocarcinoma, then PSTT or ETT, and atypical PSN. We have just seen atypical PSN does require follow-up. However, typical PSN will not require review, further investigations. Okay. Now, what is the optimum follow-up? Again, here the questions are asked on this particular topic. What is the optimum follow-up following a diagnosis of GTD? Okay, complete molar pregnancy. If you have dealing with a complete molar pregnancy, what we do, we follow up these patients on by doing the SCG. So if the SCG comes back to normal within 56 days, that is within 8 weeks, you have a complete molar pregnancy, you are following that patient with beta SCG monitoring, and the beta SCG comes to normal within 56 days, that is 8 weeks, then the follow-up will be for 6 months from the date of uterine removal. Uterine removal means suction evacuation. Okay, is it clear? You follow up these patients by doing beta SCG, serial beta SCG. If the serial beta SCG comes back to normal within 8 weeks, that is 56 days, then you have to follow further these patients for 6 months from the suction evacuation. Okay, from the date of suction evacuation. Is it clear?
Yes, sir.
Yes, sir.
Okay.
Yes.
If the SCG has not reverted to normal within 56 days of the pregnancy event, then follow-up will be 6 months from the normalization of the SCG level. Okay, suppose you are following these patients on SCG, but it has not come back to normal within 8 weeks or 56 days. Then the follow-up will be for 6 months from the time when it comes to normal. Okay, is that clear?
Yes.
What is the difference between the two? Can anyone tell me?
In one, if the HCG normalizes within 6 days, it is 6 months. Follow-up is done till 6 months from the date of
Evacuation.
But if the HCG doesn't normalize within 56 days, then she should be followed up for 6 months from the date of normalization of HCG level.
Correct, correct. Okay, here is the difference between the timing of follow-up depending upon the normalization of the SCG. Okay, suppose they give some scenario and they will say that the patient was followed up with beta SCG and the SCG has come to normal after 60 days or 65 days. What will be the follow-up? So follow-up will be for 6 months from the normalization of the SCG in that particular case, because it came back to normal after 56 days. Okay, and if
Yes.
it happens within 56 days, then it is from the evacuation, from the date of evacuation. Now in partial molar pregnancy, the follow-up is different. Okay, what we saw up till now was a complete molar pregnancy. Normalization within 56 days, normalization after 56 days. Okay, then if you are dealing with a partial molar pregnancy, the follow-up is concluded once the SCG has returned to normal on 2 samples at least 4 weeks apart. So you will follow up these patients on beta SCG. Once it comes back to normal, another sample after 4 weeks, both samples negative, the follow-up is concluded. Okay, so partial molar pregnancy follow-up, you understood? 2 samples negative at 4 weeks apart, the follow-up is completed. While in partial molar pregnancy, you have to follow up these patients 6 months, either from the date of evacuation or from the date of normalization, depending upon the timing of the normalization. Is that clear now?
Yes, sir.
Okay.
Yes.
Because these questions are frequently asked. Okay. And you have to read carefully what exactly is the information given. Then what is the treatment for gestational trophoblastic neoplasia? Women with gestational trophoblastic neoplasia may be treated with single agent or multi-agent chemotherapy. Treatment usually is based on FIGO 2000 scoring system. Okay, so GTN treatment is based on FIGO 2000 scoring system, and you have either single agent chemotherapy or multi-agent chemotherapy. Okay, for GTN, following assessment at the treatment center. PSTT or ETT are now recognized as a variant of GTN, and they may be treated with surgery because they are less sensitive to chemotherapy. So if you have a PSTT or ETT, they require surgical treatment and not the chemotherapy. While Rest of the GTN will require either single agent or multi-agent, and this will be decided by the FIGO 2000 scoring system. Again, this scoring system is very important. We will see at the end of this particular topic, because the questions are asked on this particular FIGO 2000 scoring system, because you have to calculate the score and decide whether what is the score, whether it requires single agent chemotherapy or multi-agent, because score of 7 or more will require a multi-agent and up to 6 will require a single agent. Okay, now what about the conception following complete or partial molar pregnancy and monitoring of women following a successful pregnancy after previous molar pregnancy and outcome of subsequent pregnancy? You have a patient, okay, who is pregnant and delivered currently, but she had a history of either complete or partial molar pregnancy in the previous pregnancy. Okay, women are conception following complete or partial molar pregnancy. What advice is required? Conception following complete or partial molar pregnancy and monitoring of women following a successful pregnancy after previous molar pregnancy and outcome of subsequent pregnancies. Okay, so under this we have a women are advised not to conceive until their follow-up is completed. So once you have diagnosed this particular molar pregnancy and treated, then you have to advise them not to conceive until the follow-up is completed, and duration of follow-up we have already seen. Okay, then women who undergo chemotherapy are advised not to conceive for 1 year after completion of treatment as a precautionary measure. Okay, so if the patient does not require the chemotherapy in that particular case, during the follow-up patient should not conceive. So you have to advise the contraception. But if the patient has required a chemotherapy, then they should not conceive for 1 year after the completion of the treatment as a precautionary measure. Okay, is it clear?
Yes, sir.
Duration of
Yes, sir.
contraception.
Yes, sir.
Duration of contraception,
It is
1 year if she has received the chemotherapy.
chemotherapy.
Okay. Otherwise, during follow-up, no conception. Okay. Now, in subsequent pregnancy, now what does the guideline say about the subsequent pregnancy? Pregnancy following a previous molar pregnancy which has not required treatment for GTN, you don't have to send a post-pregnancy SCG sample. Okay, so the patient had a previous molar pregnancy and GTN treatment, their treatment was not required. Okay, treatment for GTN was not required. You don't have to send the sample in the next normal pregnancy. Okay, also there is no need for the sending the histopathology of the placenta in the current normal pregnancy. Okay, so after molar pregnancy it is not indicated. Previous molar pregnancy, now normal pregnancy, no need to send the beta SCG after delivery, follow-up or the placental tissue following the normal delivery. Okay, long-term outcome of women treated with for GTN is excellent, with overall cure rate of close to 100% and pregnancy rate 80% for women following treatment for GTN with either methotrexate alone or multi-agent chemotherapy. So long-term outcome is good, cure rate is almost 100% and pregnancy rate is around 80% after the treatment with GTN, either single agent or the multi-agent chemotherapy. Okay, so this was the summary of this particular guideline. Now, what is the risk? Risk of premature menopause for women who are treated with combination agent chemotherapy. We have seen either there is a single agent chemotherapy or multi-agent chemotherapy. If you are treating these patients with multi-agent chemotherapy, or combination agent chemotherapy, these patients are at risk of development of the premature menopause. Women, especially those approaching the age of 40 years, should be warned of the potential negative impact on fertility, particularly when treated with high dose chemotherapy. Okay, contraception following treatment for GTD, safety and timing not to become pregnant until they have completed their SCG follow-up. This we have seen. Okay, then use of exogenous estrogens and other fertility drugs may be used once the SCG levels have returned to normal. So they want to plan the pregnancy. If the SCG has come back to normal, then the estrogen can also be used and the other fertility drugs can also be used for these particular patients. Okay. Now, hormone replacement therapy may be used once the SCG levels have come back to normal. So once the SCG levels are normal in that particular, she can conceive. You can use the other fertility drugs also. Even HRT is required, you can give the HRT also. Okay. Online support groups are available. especially this is important for part 3, molarpregnancy.co.uk. This is online support group, and alongside regular drop-in support is available in various hospitals, that is Charing Cross Hospital London and West Park Hospital Sheffield. Okay, now let's see about this summary is over. Now we'll go into the details of these guidelines. Okay, gestational trophoblastic disease comprises of group of disorders spanning the pre-malignant conditions of complete and partial molar pregnancies, also known as hereditary moles, through to the malignant conditions of the invasive mole, choriocarcinoma, and very rare placental site trophoblastic tumor, that is PSTT, and epithelial trophoblastic tumor, ETT. So it's a spectrum. What does it comprise? GTT? It comprises complete molar, partial molar, okay, then malignant conditions of the invasive mole, choriocarcinoma, and other placental site trophoblastic tumor, that is PSTT and ETT. The malignant potential of atypical placental site nodule, PSN, remains unclear. Okay, so for PSN it is unclear. Then if there is any evidence of persistent GTD after primary treatment, most commonly defined as a persistent elevation of the SCG, the condition is referred to as gestational trophoblastic neoplasia. So in the last slide, what we have seen is a GTD, that is gestational trophoblastic disease. It's a spectrum, and it will involve complete molar, partial molar, then invasive mole, choriocarcinoma, PSTT, ETT, all that comes under GTT. But if you have given a primary treatment for GTD and there is a persistent elevation of SCG, then the condition is called a GTN. So have you understood the difference between GTN and GTD?
Yes, sir.
Okay. The diagnosis of GTN does not require histological confirmation, while GTD requires confirmation histologically. Okay, so these are the differences between GTD and GTN. GTN, it's only persistent elevation following a primary treatment of GTD, while GTD requires histological confirmation. The diagnosis of complete mole, partial mole, atypical PSN, PSTT, ETT does require histological confirmation. Okay, while GTN does not require histological confirmation. Okay, now let's see the difference between the molar pregnancy. We have a complete mole and partial mole. So when again here the SBAs are asked, when you are dealing with a complete mole, it is diploid. Okay, while partial mole is a triploid in 90% of cases. Okay, and complete mole is androgenic in origin. There is no evidence of fetal tissue in complete mole. In 75 to 80% cases, it arises as a consequence of duplication of a single sperm following fertilization of an empty ovum. The phenomena is called as androgenesis. Okay, so you have an empty ovum which is fertilized by the sperm, and that sperm gets duplicated. Okay, so that is this phenomena, that is androgenesis, is responsible for the development of the complete mole. That is why it is diploid. Okay, so the chromosome number is same because it is 23 chromosomes of sperm gets duplicated, so it forms a diploid. Okay, 46 chromosomes. And some complete moles, that is 20-25%, can arise from a dispermic fertilization of a empty ovum. So here there is a empty ovum, but it is fertilized by 2 sperms. Okay, that phenomena is seen in 20-25% of cases. So if you are asked, commonest will be duplication of the single sperm following fertilization of empty ovum, that is 75 to 80% of cases. While in 20-25% of cases, there is a dispermic fertilization of empty ovum. So ovum is always empty in complete mole. Okay, is it clear?
Yes, sir.
Yes, sir.
Then coming to partial mole. Partial mole is a triploid. Okay, in 90% of cases you will get a triploid. Then in almost all cases it happens following dispermic fertilization of a ovum. So you have a normal ovum that will have a 23, and there is a dispermic fertilization, so another 23 and 23 are getting added, and you will have a triploid partial mole. Is it clear now? This
Yes, sir.
dispermic fertilization is also seen in complete mole, but their ovum is empty. Okay, and that is responsible for only 20-25% of cases, while normal ovum with dispermic fertilization will lead to partial mole. Okay, and it will be triploid. there will be evidence of fetal tissue or RBCs, and 2 sets of paternal haploid chromosomes and 1 set of maternal haploid chromosome is seen in partial mole. Okay. Now coming to the GTD, that is hydatidiform mole, invasive mole, choriocarcinoma, PSTT. What is the prevalence? It is 1 in 714 live births. Okay, Asian women have higher incidence compared with the non-Asian women. So 1 in 387 versus 1 in 752 live births respectively. So for Asian women, it is high incidence around 1 in 387 as compared to non-Asian, that is 1 in 752. So overall, you can remember 1 in 714, but it is almost what you can say higher or double in cases of Asian women. Incidence of GTD is associated with age at conception being higher in the extremes of age. So extremes of age, higher incidence of GTD you get. So women aged less than 15 years, it is 1 in 500 pregnancy. And if the woman is more than 50 years of age, then it is almost 1 in 8 pregnancy. Okay. So extremes of age, it is common, and less than 15 years, it is 1 in 500, and less after 50 years of age, then it is around 1 in 8. And overall, it is 1 in 714. Asian will have higher incidence. Okay. Then GTN may develop after molar pregnancy, a non-molar pregnancy, or live birth. So this GTN can happen following a molar pregnancy. We know that GTN is nothing but the after primary treatment or after the pregnancy event, there is a persistent elevation of SCG which normally should come back. It does not happen, and this can happen following molar pregnancy. A non-molar or live birth also can lead to GTN. The incidence after live birth is very rare. It is 1 in 50,000 cases. Okay, following live birth, the rarest is following the live birth. Okay, vaginal bleeding is the commonest presenting symptom of molar pregnancy in 60% of cases. Gestational age at presentation is reduced from 11 to 10 weeks between 1996 to 2006. So initially the presentation was late. It has come towards lesser gestational age. Around 10 weeks the patients are presenting, and this is mainly because of the ultrasound diagnosis. Okay, presentation of abnormal USG is increased from 1% to 12% over the same period of time. Okay, so abnormal ultrasound prevalence is increased because of the diagnostic facilities. It is initially it was only 1% presentation, now it has become 12% presentation. Okay, now what are the USG features? In complete molar pregnancy, what you get, this is also data interpretation. You may be given some figure or you may be given some description, and you have to identify. So what is the ultrasonography feature? In complete molar pregnancy, there will be polypoidal mass between 5 and 7 weeks of gestation and thickened cystic appearance of villus tissue after 8 weeks of gestation with no identifiable gestational sac. So there is no identifiable gestational sac, and there is a polypoidal mass between 5 and 7 weeks of gestation and thickened cystic appearance of villus tissue after 8 weeks of gestation. Okay, what you get in a partial molar pregnancies are associated with enlarged placenta or cystic changes within the decidual reaction in association with the either empty sac or delayed miscarriage. Okay, using these criteria, a reasonable sensitivity for complete mole is 95% and 20% for partial mole. So partial molar pregnancies are associated with enlarged placenta or cystic changes within the decidual reaction in association with either an empty sac or delayed miscarriage. Using these criteria, reasonable sensitivity for complete mole is 95% and 20% for the partial mole. Additional ultrasound features like finding of multiple soft markers including cystic spaces in the placenta, the ratio of transverse to anteroposterior dimension of the G-sac greater than 1 to 1:1.5. These features may be of help in the diagnosis of partial molar pregnancy. Okay, so these features also you remember, because sometimes they give these features also, that finding of multiple soft markers including cystic spaces in the placenta or ratio of transverse to AP dimension of the gestational sac greater than 1:1.5. Okay, these features may be of help in the diagnosis of partial molar pregnancy. The definitive diagnosis of molar pregnancy is made by histological examination only. Okay, ploidy status and immunohistochemistry staining for P57, a paternally imprinted gene may help in distinguishing partial from complete molar pregnancy. This is also SBA. The ploidy status and immunohistochemistry staining for P57. Okay, so this P57 will be positive for partial molar pregnancies. That will differentiate partial molar pregnancy from the complete molar pregnancy. Okay, so differentiating features between complete and partial will be asked. So complete molar, there is a absence of fetal tissue, extensive hydropic change in the villi, and excess trophoblast proliferation is seen in the complete mole. While in partial mole, you have presence of fetal tissue, then focal hydropic change to the villi, and some excess trophoblastic proliferation. Okay, here there is extensive trophoblastic proliferation, here there is some excess trophoblastic proliferation, and here there is extensive hydropic change, while here it is a focal hydropic change in the partial mole. Okay, complete molar pregnancies are not associated with fetal parts, and therefore suction removal is the method of choice for uterine removal irrespective of the uterine size. So irrespective of the uterine size, suction curettage is the method of choice for complete molar pregnancy, as there is no fetal parts. While medical removal of complete molar pregnancy should be avoided if possible, irrespective of the agents used. Okay, risk of developing GTN and requiring chemotherapy was 16-fold higher with medical methods than surgical methods. So risk of developing GTN is high if you go for medical methods. Okay, then what are the theoretical concerns supported by the clinical experience? Use of potent oxytocic agents because of the potential to embolize and disseminate trophoblastic tissue through the venous system, leading to adult respiratory distress syndrome, similar in presentation to the amniotic fluid embolism. That is why we have seen in the summary that oxytocin use is not recommended. Okay, then twin pregnancies where there is a non-molar pregnancy alongside a molar pregnancy, and the woman has decided to terminate the pregnancy, or there has been a demise of the coexisting twin and the size of the fetal parts deters the use of suction curettage, medical removal can be used. So these are the indications for the medical methods for the termination. Okay, then there is a higher rate of incomplete removal with medical methods. The risk of this increasing the need for a treatment for GTN is 13 to 16% with complete molar pregnancy and 0.5 to 1% with partial molar pregnancy. Okay, so need for treatment is less with the partial molar pregnancies, that is 0.5 to 1%, and means GTN treatment will be required in 13 to 16% cases of molar pregnancies and 0.5 to 1% cases of partial molar pregnancy. These figures 13 to 16% and 1% are also important. Okay, the risk of this increasing the need for medical treatment, need for treatment for GTN is following complete molar is 13 to 16% and 0.5 to 1% for partial molar pregnancy. Now need for anti-D. Poor vascularization of the should we give anti-D or should not? We should not give. What exactly the guideline says? Listen it carefully. Poor vascularization of the chorionic villi and absence of D antigen by the trophoblastic cell means that anti-D prophylaxis is not required for complete molar pregnancy, because there is no fetal tissue, there are no RBCs. Then why should we give the anti-D? Per se, theoretically, it is not required. However, it is required for partial molar pregnancy because there is a fetus or there is a RBCs. However, the confirmation of the diagnosis of complete molar pregnancy may not occur for some time after removal, which could delay administration of anti-D. If the diagnosis of complete molar pregnancy cannot be established within 72 hours, anti-D prophylaxis can be administered for practical reasons. So even the diagnosis is by histopathological examination, but histopathology will not be available within 72 hours after termination, and hence you have to give the anti-D. Okay, suppose you are assuming that it is a complete molar pregnancy, but the report is not in that particular way, then what? You have already crossed the limit of 72 hours. So for all practical purposes, you will give anti-D. Is it very clear to all of you?
Yes,
Yes,
sir.
sir.
Okay.
Yes, sir.
Now, repeat surgical removal. This also we have seen. If there is a persistent heavy vaginal bleeding and evidence of retained pregnancy tissue on USG, it requires a repeat surgical removal when prior surgical removal was done for suspected GTD. expediting surgical management in case of acute hemodynamic compromise is the priority. Consider balloon tamponade or uterine artery embolization to reduce the risk of hysterectomy for women who wish to preserve fertility. So these are the other options. You can consider balloon tamponade and uterine artery embolization to avoid the risk of hysterectomy, especially when the patient is expecting fertility in future. Embolization will not always stop the bleeding, but will permit management of the blood loss, and bleeding from the vaginal meatus can be reduced by compression from the vaginal pack. So vaginal packing if it is a bleeding from the vaginal meatus. Okay. Outside the context of acute compromise, there should be consultation with the relevant GTD referral center before performing surgical management for the second time in the same pregnancy. This also we have seen in the executive summary. Okay. Management of a twin pregnancy of a viable fetus and presumptive coexisting molar pregnancy. You have to refer these patients to fetal medicine and GTD center. There is an increased risk of early fetal loss, 40% chance of early fetal loss, and premature birth, 36% in a twin pregnancy of a viable fetus and coexisting molar pregnancy. So early fetal loss is 40% and premature birth 36 means 1/3 patients will go into premature labor. Okay, the incidence of pre-eclampsia is variable. The rates are as high as 20%. Okay, so if you have a twin, there is a high chance that the 1/3 patients will go into preterm labor, 40% will have early fetal loss, and 20% will have a pre-eclampsia. Okay, then PSTT or ETT management. Registration and care at GTD center. Their presentation and behavior are different and less predictable. Hysterectomy is curative in many cases with localized disease in women with long-term periods since the antecedent pregnancy and or with distant or extensive metastatic disease. Intensive chemotherapy plays a major role. Okay. So surgical treatment is indicated. However, if there is a long time period since the antecedent pregnancy, then there is a role of intensive chemotherapy. However, PSTT and ETT will require a surgical management. Okay. The management of placental site nodule or atypical PSN. PSNs are regarded as a benign finding of little clinical significance. There have been reports of PSN, that is placental site nodule, with or without atypical features, which have either been admixed with PSTT or ETT, or that they have subsequently progressed over time to PSTT or ETT. Okay, this link to cancer appears strongest with the atypical PSN and may occur in 10 to 15% of women. The condition often presents with vaginal bleeding resulting in endometrial biopsy or because of hysteroscopic biopsy performed for other reasons. So see, PSN is there, but these PSN, especially when they are atypical PSN, they can progress to PSTT and ETT. And the chance is around 10 to 15% of patients. Okay, the commonest presentation is vaginal bleeding, and these patients may be taken for endometrial biopsy and they will bleed heavily. This is what is the interpretation of her. Is that clear? So if it is a atypical PSN, it may progress to PSTT or ETT in 10 to 15% of cases. Okay. Those women who have completed their families may wish to consider hysterectomy in absence of metastatic disease. Women who desire more children require careful counseling and further testing. Treatment for GTN. Now here the scoring system has come. Okay, now you have a GTN, you have to do the scoring as per the FIGO 2000. Okay, scores of 6 or less is a low risk and single agent intramuscular methotrexate alternating daily with folinic acid for 1 week followed by 6 days rest. Okay, so only methotrexate is required along with folinic acid. If you have a score of 7 or more, they are at high risk and require treatment with IV multi-agent chemotherapy. So 7 or more will require a multi-agent chemotherapy. So when they may give some description, and you will have to find out the score and decide whether she requires a single agent chemotherapy or the multi-agent chemotherapy. Okay. Now, multi-agent chemotherapy will include combinations of methotrexate, dactinomycin, etoposide, cyclophosphamide, and vincristine. Okay. Treatment is continued until the HCG level returns to normal, and then for a further 6 consecutive weeks. So you have to continue the treatment 6 weeks after the HCG has come to normal. and the agents are methotrexate, dactynomycin, etoposide, cyclophosphamide, and vincristine. Okay, women suspected of having choriocarcinoma require more extensive investigation in the specialist center. Any women with a score of 13 or greater is now recognized to have a higher risk of early death within 4 weeks, often due to bleeding into the organs or late death due to multi-drug resistant disease. So 13 or more, there is a high chance of death, early death. Within 4 weeks of the diagnosis, the patient can have death. Okay, while for treatment purpose, you have a low risk, you have a single agent chemotherapy and multi-agent chemotherapy depending upon score, 6 or less and 7 or more. Okay, this is what is the FIGO scoring system. Okay, so the scores are 0, 1, 2 and 4. There is no score 3. Please remember, there is no score 3. You have score 0, score 1, score 2 and score 4. Now, if the patient's age is less than 40, there is a 0 score. If it is a 40 or more, okay, remember what exactly is given. If most of the time the in RCOG exam, you will find whatever it is, they will give you the borderline. You get confused whether the 40 comes at 0 or it comes at 1. Okay, so 40 is included into the 1. Okay, then antecedent pregnancy, whether index pregnancy was a molar or abortion or birth. Okay, we have seen live birth is rare. Okay, but if it is there, then the score is high, 2. Okay, if it is a molar, it is 0. Commonest is a molar. Okay, then abortion has got a score of 1. Interval of months from the end of the index pregnancy to the treatment. Okay, so when was the pregnancy event? Okay, which has lead to the GTN. If it is less than 4 months, then score is 0. If it is between 4 to 7, okay, less than 7, okay, then 1. But if it is 7 up to 13, okay, less than 13, I mean to say, then it is 2. And if it is more than 13, then it is 4, score of 4. Is it very clear? Interval of months from the index pregnancy, less than 4, there is a 0 score. Then 4 to 7, okay, 4 to less than 7, remember it is less than 7 is 1. Then 7 to less than 13 is 2. Okay, and 4 is a more than or equal to 13. Then pre-treatment beta HCG. So when the patient is presenting, what is the beta HCG level? If it is less than 1000, 0. Again, they give the borderline. They will give you 1000. Where does it come? It comes in 1. Okay, 1000. Okay, to 10,000. Okay, less than 10,000. 10,000 comes here. 1000, but 9,999 will come here. Is it clear? Is it clear?
Yes, sir.
Yes, sir.
While
Yes, sir.
10,000 will come, so please do not go wrong in calculating the score. 10,000 to less than 10 raised to 5, that is less than 1 lakh. Okay, that is 99,999 will have a score of 2, but 1 lakh will have a score of 4. Okay, then what is the largest tumor size, including the uterus? Okay, if it is less than 3 centimeters, then 0 score. 3 but less than 5, then it is 1. If it is more than or equal to 5, then there is a score of 2. Okay, more than 5 centimeters, then it is a score of 2. There is no score for here. Okay, then site of mets, if you have a lung mets, score is 0. Spleen, kidney, it is 1. GIT mets is 2. Liver and brain, it is 4. Okay, so they give you a description, these are the mets found. Suppose you get a liver brain mets, directly score goes 4. Okay, and just see what is the beta HCG. If it is more than say 1 lakh, then 4 plus 4 becomes 8. Definitely more than 7, then it requires multi-agent. You just have to see whether it is 6 or 7 total score. Okay, so remember these particular criteria. Then number of mates. Okay, if there is a 1 to 4 mates, then it is score is 1. If there are 5 to 8 mates, then 2. And more than 8, remember more than 8 means 8 is included here, but 9 is included here. Okay, how many mates are there? If you find 9 mates, it will have a 4 score, but 5 to 8 will have a score of 2. Then previous failed chemotherapy, can have either score of 2 or more than 4. Generally, this option is not given in the scenario, but here they give you lot of confusion. Okay, single drug failure score is 2, multi-drug failure is a 4. Okay, the cure rate for women with score of 6 or less is almost 100%, while the rate for women with score of 7 or greater is 94%. Okay, high score 94% success rate, score is less than 100% success rate. Okay, now PSTT and ETT are the rarest form of GTN. They contribute around 0.2% of all GTD. They tend to produce less SCG. They are confined to the uterus for longer and more often involve lymphatics and are more chemoresistant than other forms of GTN. Hence, they are not managed according to the FIGO score. Most important prognostic factor for adverse outcome is interval to presentation from the last known or presumed causative pregnancy. If it is interval more than 48 months, there is a 100% death rate regardless of the stage and despite of initial favorable responses to the treatment. So PSTT and ETT will have the poor prognosis if they present more than 48 hours. Okay, 100% death. Then presentation within 48 hours are nearly all long-term survivors. A more recent series where more intensive treatments were given to PSTT and ETT patients with a long-term interval from their causative pregnancy reported improved survival rate, but still over 50% died in this group. Stage 4 disease has also now emerged as an independent poor prognostic factor. Subsequent pregnancy risk. The risk of further molar pregnancy is low, approximately 1%, and is associated with more with complete than partial mole. Okay, so once there is a molar pregnancy, the risk of developing molar pregnancy in subsequent pregnancies approximately 1%. Remember, 1%. This can also be an SBA. What is the risk of developing molar pregnancy in the next pregnancy? If there is a previous molar pregnancy, it is 1%, and that is also more with the complete than the partial mole. Okay, women who become pregnant following a molar pregnancy are not at increased risk of maternal complications. However, women exposed to molar pregnancy prior to the index birth were at almost 25% increased risk of preterm birth, whereas women with at least one birth between the molar pregnancy and the index birth were at increased risk of LGA and stillbirth. Okay, remember, women who become pregnant following a molar pregnancy are not at increased risk of, so maternal complication nil. Okay, in a subsequent pregnancy. Then what can happen? Women exposed to the molar pregnancy prior to the index pregnancy, 25% chance of preterm birth. So previous molar in this pregnancy, there is a 25% chance of preterm birth. However, if there is a one birth in between, that means there is a molar pregnancy followed by one delivery, and now this is the index birth. In that particular case, they are at risk of LGA, okay, and stillbirth. So here the read the SBA, what is given, what has been asked to you. If there is a previous molar pregnancy, in the current pregnancy, there is a 25% chance for the preterm birth. If there is a last molar pregnancy, then there is a another pregnancy, and now is the index pregnancy, then the lady is at risk of developing of LGA and stillbirth. Is it clear?
Yes,
Is
sir.
it clear? Yeah, okay. Now chances of having pregnancy appear to be equally good at around 83% after either methotrexate alone or multi-agent chemotherapy such as EMA or CO, that is etoposide, methotrexate, actinomycin D, cyclophosphamide, vincristine, that is oncovin. Okay, so the fairly high chance of conception, we have seen 83% or 80% around is the subsequent pregnancy rate. In the summary also we have seen, okay, 80% chance of subsequent pregnancy. Okay, however, menopause can occur earlier than expected for women treated with combination agent chemotherapy. 13% will have a premature menopause by the age of 40 years and 36% by the age of 45 years. So if multi-agent chemotherapy is given, in that particular case, premature menopause chances are increased 13% below 40 years and 1/3, that is 36% by the age of 45 years. Therefore, women approaching 40 years of age should be counseled regarding the possible negative effect on the fertility. Okay, now where are the GTD treatment centers. There is one at Charing Cross Hospital, London. Other is at Sheffield, and third one is at Dundee. Okay, so London, Sheffield, and Dundee. That was also SBA long back. Okay, that they have given London, Sheffield, Dundee. Then other options where one city was different. Some two options will be correct. Third option was wrong. So remember London, Sheffield, and Dundee. Evaluation of the checkpoint immunotherapy such as pembrolizumab in the management of multi-agent relapse disease. So this is under research, pembrolizumab. Okay. So that finishes our topic on gestational trophoblastic disease. Thank you.